So we've been hearing about the biology of the diabetic, and Bonnie, I was fascinated in this bioinformatics. Are you saying that with further research that maybe diabetics are going to have a different wound or bacterial informatics than non-diabetics?
So I would say that much has yet to be determined. So we really need to look at those different populations of people to assess that. I think that a lot of what we're going to find is that, in fact, it's not necessarily related to what one particular species, or maybe even two, but really the combination of many together, and also in combination with function. And I think that is really the kind of where the bioinformatics might be going. And one of the major issues with the bioinformatics right now is that it's very hard to get the metagenomic sampling for whole genome shotgun. And the reason for this is when you do sampling from the skin, you get very low biomass. And so there's a lot of techniques and also work that needs to be done in bioinformatics to look at that kind of low quantity of DNA and be able to assess and understand both the community and the functional components of those data and how they relate to the clinical factors, which requires a lot of fun statistics.
So you've heard a very carefully worded PhD scientist's point of view, and maybe I can just give you a clinician's point of view. I think there is a difference, and I think we'll better define it with these newer techniques, but cultures for decades have shown differences between what you get from wounds of diabetics and non-diabetics from the same area, and what available data there are from the newer microbiological studies that are using these advanced techniques that Bonnie has referred to are suggesting the same thing. So I think we're going to define that whatever the immunological perturbation is that diabetic patients have, it's going to lead to different microbiology.
Dr. Andros.
I very much enjoyed that. Having heard 4 wonderful talks, I will hope that you might give us some perspective, both from Europe and America. When should the clinician who is treating a patient with an infected diabetic foot ulcer call an infectious disease specialist?
You want to take it? Right.
I would say on day 1. Is that okay?
For every patient?
Is that too bold? Oh, I usually hope that...
When do you arrive? Do you arrive when we call you on day 1? Do you arrive maybe on day 3 or day 6?
No, I'll
answer,
probably be there
David?
before you call me. No, actually,
They send the resident.
Oh, that's if the last thing ends in ology, then usually there's more of a delay. Go ahead.
I would prefer to be there from day 1, because on day 1, you, as an infectious disease specialist, you can have most influence on the outcome of the disease, particularly because you can make sure that all the proper methods are used for diagnosing the infection, that's 1, and 2, to make sure that all the proper specimens are taken in the right way to make sure that you are actually targeting with antibiotics what you should be targeting. And I found that my colleagues that are not really involved into infectious diseases are not really strict in doing whatever they should do to get the best culture results and the best strategies early on in treatment. Because, well, you win the first battle, you're more likely to win the war.
Right? May I ask a follow-up question to that?
Sure.
Now, you can answer this as well, Edgar. What if the patient's an inpatient versus an outpatient?
What is worse, you mean?
Let's assume the patient is an outpatient versus an inpatient, and I could be more specific and make it say that you've seen the patient at 4:30 on Saturday afternoon, and you're about to get a phone call at day 1 for 36 on day one. What then? Are you going to send your PA or?
Well, usually the patients that are treated on an outpatient basis are not as bad off as the ones that are directly admitted to hospital where you see them anyway as an in-hospital service. So I think, and those patients would probably do very well on a small spectrum antibiotic, outpatient, oral, and do not need any further treatment, maybe some debridement, but that's it.
Would you see them on that day, or would you just email them?
Depending on what colleague sees them, I would trust his judgment. Now, if they would then be admitted to the hospital, that means that there's something wrong, and then, well, I probably would like to be involved straight away. But you can't treat all the patients that come to other patients, other doctors' outpatient clinic. So you have to use your resources well, I guess. So I would save my resources for the worst patients.
Thank you.
I think there are three critical things that you have to deal with when you're being called about a patient with a diabetic foot problem. The first is, do I need a surgeon if I'm not a surgeon? So you need to recognize the signs and symptoms that suggest the possible presence of deep abscesses, necrotizing fasciitis, the kind of wounds that will not get better no matter what antibiotic you give them if you don't drain and resect infected necrotic tissue. So that's number one, and ID docs are frequently called for help with that. The second is to ensure you get an appropriate specimen for culture, and the third is to pick your empiric antibiotic regimen, waiting for the results of the culture results to come back and sensitivity tests so that you can then pick your definitive regimen to finish the course. So depending upon how sick the patient is and how knowledgeable or ignorant the physician is, that would determine when you need to see the patient as an ID consultant.
But also you would tend to be earlier, is that right, as
Yes.
Edgar suggests?
I would much rather be, as Edgar says, called right from the beginning. And my response when I'm called is that I can only give you a generic answer to your question until I see the patient, and then I can give you a specific answer.
I would like to see them as well.
So wearing my administrative hat, Ben, I agree with you 100%, because I think working together, maybe we can keep the patient as an outpatient, or come up with a plan. Do we need a surgeon? Do we need revascularization? How do you offload? What antibiotics? Along that line. David?
I'll be really quick. There's people waiting. But let's just make the assumption, ladies and gentlemen, or lady and gentlemen, that we break the code, Bonnie, and we can identify a healthy and an unhealthy microbiome in these patients. Do you foresee in the near future us adding bacteria to a wound, just like we do with the gut and a stool transplant?
Mm-hmm. Well, we probably won't be doing stool transplant into wounds, although they obviously are effective at treating C. difficile diarrhea. But I do think it's possible that we will find healthy microorganisms as opposed to pathogenic microorganisms, and that one method of accelerating wound heal could conceivably be a probiotic approach with using microbes. Anybody else have any?
My response to that, wearing my ecology and evolutionary biology hat, is really making sure that when we look at the organisms that we're putting into a sample, how closely related are they? Could there be events of horizontal gene transfer where you actually have something that would be just a commensal organism, such as Staphylococcus epidermidis, that is then transferring? It's been known to have a repository of genes, so could it be actually doing some harm? So we need to really assess and really think through the complete phylogeny of what we're actually putting in there to understand whether or not it would truly be beneficial.
My question's two-part. First is, how are you defining the osteomyelitis as cured? And the second is related to that, because most of the ID doctors at the hospital we work at say that if there's a bone infection, basically if we don't surgically remove it, that it's just going to be put in a quiescent state. So how are you defining that osteomyelitis is cured?
That really is probably the single biggest question in the world of diabetic foot osteomyelitis. And one of the reasons at this point the Food and Drug Administration has yet to develop what's called guidance for industry on how to do an osteomyelitis study. That's why no new antibiotic's been FDA approved for the treatment of osteo within the last 20 years because of this lack of guidance for industry. And there are a number of reasons for that, including how do you what's the role of surgery? How long do you treat? How do you diagnose? But to me, the biggest question is the endpoint. You know, Ben presented that one study where they showed no more localized or systemic signs of infection. Javier Aragon-Sanchez claims, and I've got into rather vociferous arguments with him about this, that the definition of a cure of osteomyelitis is if you heal the ulcer over the bone. But I think most people in this room have healed wounds over infected bone. I don't buy that, yet he has used that as his endpoint in almost every clinical trial he's published. So I really don't think there's a good question for that, a good answer for that, and I'd like to hear everybody else's opinion, because that to me is the biggest, you could argue IV, PO, you could argue, you know, duration of therapy, role of surgery, but that's the big question. How do you define it? I don't know that it's been answered.
So I think Warren is correct in what he said, but then what you need is a practical answer to what do I do tomorrow when I go see my patients. So here's the way I look at it. Number one, you have to follow them for a minimal duration, I would say, of 6 months and preferably for a year before we use the term cure, and even then we rarely use it. We use the term remission. So it's a little like cancer. You have to have a 5-year follow-up period before you start talking about the possibility of cure. Secondly, I do want to see the wound heal, but I agree with Warren, and I've had the same argument with Javier Aragon-Sanchez, that healing of the wound is necessary but not sufficient. Thirdly, what I'd like to see is the ESR, especially if it was significantly elevated, which it usually was, come down to normal range. That to me is very reassuring. And thirdly, I would have an imaging test, which might just be plain X-ray, because there are very characteristic findings on plain X-ray of bone healing. They lag the clinical findings just as they do when you first diagnose osteomyelitis. But if I begin to see sclerotic bone and resolution of findings that are most compatible with bone necrosis and infection, that's very reassuring. Some of the more sophisticated advanced imaging procedures, I'd like to see absence of inflammation, for example, on a SPECT CT scan. So that's kind of the pragmatic approach that I take.
I think adding a surgical perspective to that, too. It's one thing if you do that without addressing the biomechanics or the arterial disease, the associated things that diabetics have, including good blood sugar control. There is a high incidence of recurrence.
I had kind of a similar question just based on this question about medically or surgically for osteomyelitis. Specifically, one of the articles was looking at basically an equivalent cure at 6 and 12 weeks. So if you're getting to 6 weeks and you're not getting a cure, what then? Are you going back to the drawing board? Are you going to a surgical cure? You know, are you kind of starting over? Are you reanalyzing the wound? And a secondary question, if I could, just looking at some of these advanced technologies such as PCR, 10-PCR, and MoldedToff. Are we working with industry to try and let them know that, you know, these reports that they're printing up and that this information that they're giving us, while maybe interesting in academia and in, for an academic microbiologist is not very useful, you know, on the battlefront, as it were?
Maybe I can take the first part, and maybe Bonnie, you can handle the second part. So the study that Seneville did comparing 6 and 12 weeks, at 6 weeks you're not going to know whether osteomyelitis is cured. So you have to take a leap of faith. You have to say that I think that's sufficient duration therapy. It's like with endocarditis. You don't know for sure that it's gone. You have to keep taking blood cultures, hope that they're negative, and look for signs and symptoms that suggest that the patient's doing well. I think you then have to follow those patients up, which he did in his study for a full year before he then declared that they went into remission. He did use that term remission, even though he followed them out for a year.
With respect to the PCR technologies, you really need a biomarker to go after, and so a lot of the exploration for the biomarkers will come out of the metagenomic work that we're talking about, but they have yet to be determined based on many different clinical factors. But PCR is a fantastic approach for when you do actually have the have a known gene or a known biomarker that you're looking for, it's a great way of quickly finding that biomarker and diagnosing a patient. So most certainly working with industry for that is very important.
I think we have to also be clear, this isn't an all or none. There are some cases that maybe you're better off, and Ben showed those slides of treating osteo with medical therapy versus, and I would go back, is what's your availability of a surgeon or someone who can deal with the surgical into this and associated soft tissue infection. But I don't think we're applying either or to all wounds. Clearly, and correct me if I'm wrong on the panel, but a infected bone, prominent met head that's sticking out of the wound, I don't think any of us are going to treat that with 6 weeks of antibiotics and no surgery.
I agree.
Yeah, I think there's still a place for so-called surgical cure. If you've got an osteomyelitis, the distal phalanx of the hallux, and the distal phalanx of the hallux is surgically removed, you've got a cure. There's no reason to give any more than a couple days of antibiotics. And the recent article that Ben showed, which compared medical to surgical therapy, the surgical therapy only used 10 days of antibiotic. And I think that's totally reasonable. I have, where I end up with a problem is, let's say I have an osteomyelitis of the fifth metatarsal head and shaft, and the surgeon goes in and removes the fifth metatarsal down to the base because they want to preserve the base because the attachment of the peroneus longus tendon. Well, I'm sorry, if you would have removed the entire fifth metatarsal, I wouldn't need any more antibiotic. Now I don't know. I don't know whether I need to continue antibiotic therapy or not. And maybe some of these abbreviated courses that are starting to show up in the literature, like a 10-day course or a 20-day course that was shown about 2 years ago in a paper in Journal of Foot and Ankle Surgery, may be the way to go.
And just going back to, by the way, I really enjoyed all the sessions. I'm actually an ID fellow, and I think the problem in addressing this question of osteomyelitis in my mind, and I'd like your opinion on that comment, is that it's a heterogeneous disease. We're talking about multiple variables that are affecting this definition of osteomyelitis in this patient. So for example, you've got the location, just as was mentioned, you've got the organism, you've got the host, you've got you've got all these parameters, the glycemia, things like that. And I think that's why it's so hard to pin it down and say, surgical versus medical, and you have to use judgment. So that was just a comment. But, one of the things that I've felt for a while in my personal experience, and I wanted you to comment on that, was I think that the more that the patient has delayed in accessing care, I think the less likely that medical therapy alone is going to resolve the problem. That's been my impression, and I don't know if the panelists would like to share their thoughts on that. Thank you.
Well, let me just take the last part of what you said. The longer that the patient delays in coming to see you, the more likely it is that there are problems either with the patient and their interaction with the medical care system or the medical care system that is available to the patient. And if you have a patient like that who's waited, like the patient that Warren described from the University of Geneva, 10 days taking photographs of his foot as it became necrotic, that's a patient who needs to come in and have the osteomyelitis taken out because he's not going to take 6 weeks of antibiotic therapy in a reliable way at home.
Yeah, it's very interesting that you brought up a point about how heterogeneous this disease is, and it is, and that's one of the problems we all deal with when we treat these every day. But unfortunately, the ID community as a whole has not looked at it that way. They've taken a one answer for all of this. And it doesn't matter where in the world I lecture, to what specialty I lecture. I just was lecturing at the Arizona Infectious Disease Society last weekend. And I said, how long do you have to treat osteomyelitis? And everyone says the same thing, 6 weeks. And what route of therapy? IV. So it's a universality that every ID thinks you need 6 weeks of IV antibiotic therapy for any osteomyelitis, yet as you so rightly pointed out, there's so many variables that we have to get away from that. This one-size-fits-all ID approach to osteo is just wrong. And by the way, that's not based on any human evidence.
And to add to that, Warren, too, one thing you missed is the presence of peripheral arterial disease and the biomechanics, because if someone's going to continue to walk on a plantar wound, you can throw every antibiotic you want at them. You can see them every week, and again, the data shows we are not good offloaders. So there is a heterogeneous population, and we have to really treat each patient individually. Maybe what we'll do different from other panels, I'd like to go down and have each of the panelists maybe give one last tidbit or pearl, or as we say, maybe even a rat turd if you want, but just a final summary. Marco?
Clinical science, skin is very difficult to be assessed. Always remember that you're dealing with a foot where you have intertriginous zone, so difficult germs you have to consider, and particularly do consider what we call in dermatology the hydrolipidic film, which is something is going to protect the skin from bacteria.
So related to that, I think that as we start to look at all of these different metagenomic communities of bacteria and others, it's important to use all the clinical data that we have rather than doing a one-by-one approach to our analyses. And there's a lot of new methods that are out there for doing that, and I think it's important for people like myself who are genome scientists and really computer scientists by training to really glean the knowledge that you have, the practical knowledge and the understanding of what these clinical phenotypes look like to really dive into finding meaningful therapies.
I think that getting a good culture specimen and using the results of that culture specimen to prescribe antibiotic therapy is crucial. I think if you don't do that, you'll find yourself in trouble in at least a minority, if not the majority of your cases a few days later, and that's when you call the ID doc and he says, well, we don't have a culture. He's been on antibiotic therapy. It's very difficult now for me to guess what to do. I may have to stop antibiotics and try and reculture him in a few days. So getting an appropriate specimen, which I believe, and I think that the results of the Codify study will soon show, means getting tissue and not a swab, and using those results to constrain your antibiotic therapy to the narrowest spectrum that's appropriate to the organisms that are found.
Yes, I completely agree. I hate it when I'm called after 4 days and they ask me, what would you have done with this patient? I think that your comment was very correct. It's a heterogeneous disease, and I think that the most important factor is maybe chronicity. Because if you have a long-lasting episode of osteomyelitis, you're bound to have a lot of necrosis in the bone, and that will act as a foreign material, and that will lead to a very long duration of antibiotics and probably need surgery.
If you have a couple of months, read everything Ben Lipsky's ever written. No, I will tell you, this is a practical hint, but it's not purely medical, and I'm only half joking about that, is one of the most valuable things I ever did, and I came to it relatively late in the last year or two, is that PubMed has a service, it's called MyNCBI, and you go on pubmed.gov, and you can sign up for email alerts whenever a paper in any area of interest of yours is published in the world literature. So for instance, I have osteomyelitis, diabetic foot infections, and onychomycosis. Don't ask me why. But my point is that...
And Ben Lipsky.
And Ben Lipsky, yeah. Well, that's... The diabetic foot and Ben Lipsky are ubiquitous. The point is that and you said it for every day, every month, every week. So every Monday morning, I get an email that has all of the papers that have been published in the world literature in that last week. And that is an incredibly valuable tool because as Ben shows on a slide he has where he looked at the Web of Science, the number of articles that have been published in the area of diabetic foot in the last 20 years have gone from something like 20 a year to 300 or 400 a year. And that's how impressive the numbers have been. So in order to really keep up with this knowledge base in this specialty try doing that. I think it's very valuable.
So with that, we're going to end the evening news. Tomorrow, remember, you're back in the hotel with the workshops that are beginning at 7 a.m. I'd love to thank the panel, and most of all, I'd love to thank the audience. You all have, it's been a long day, and I hope the interaction has been well worth your while. Thank you.